Supposing you get a knee problem, it presents with pain, swelling, deformity, and loss of function. The functions of the knee are not only gait, weight bearing, the stance and the swing phase, but they are also sitting on a chair, squatting, and sitting cross legged. So that is the loss of function component of it. Then you think of a diagnosis, and in the diagnosis there is a site of lesion, there is a nature of lesion, congenital, traumatic, inflammatory, neoplastic, degenerative, metabolic, paralytic. There is a cause of it, there is an effect of it, and there is an association of it. So that diagnosis you have to make. Now let us start considering the sites and what are the common diagnoses there. The bones articulating are lower end of femur, the upper end of tibia, the patella. In the lower end of femur, you have osteochondritis dissecans, which presents with locking and a foreign body sensation and can sometimes be seen on X-ray and is treated by excision of that osteochondritis dissecans mass. Then you have fractures of the lower end of femur, upper end of intra-articular fractures of the upper end of tibia, which will be certainly dealt elsewhere, not here. In the patella, you have chondromalacia patelli, but you have recurrent dislocation, and of course, we have made a beautiful video on recurrent dislocation. In the ligaments, you have capsule, you have the anterior cruciate, the posterior cruciate, the medial collateral, and the lateral collateral ligaments. Whenever they are injured or they are lax, they present with laxity or instability. And ACL is tested by anterior drawer and the Latchman test. The posterior cruciate by the posterior drawer. The medial collateral, when it is unstable, leads to valgus instability, and lateral collateral to varus instability. Besides this, if you are asked other ligaments, you can say arcuate ligament, which arches around the tendon of the popliteus, the coronary ligaments, the meniscofemoral and the meniscotibial ligaments, which connect the menisci to the tibial and the femoral condyles. Then you have ligaments arising from the lateral posterior horn of the lateral meniscus, which go anterior and posterior to the posterior cruciate ligament, which are called as ligament of Risberg and ligament of Humphrey. Ligament of Risberg and ligament of Humphrey. So here we show you that this is the femur lower end, here is the tibia, this is the patella, and we have made the patella transparent so that you can see the anterior cruciate ligament attached anteriorly to the tibial condyle and to the lateral condyle, and remember it by lamp. Lateral condyle, anterior cruciate ligament, medial condyle, posterior cruciate ligament. So that is the posterior cruciate ligament here, and this is the anterior cruciate ligament. Then this is the medial collateral ligament, and this is the lateral collateral ligament. The lateral collateral ligament is held by the tendon of the biceps and the iliotibial band. So that is called as the lateral ligament complex. Then the quadriceps muscle, the vastus intermedius, the rectus femoris, the vastus lateralis and medialis come and get attached to the patella, forming what is the medial and lateral patellar retinaculum, and then through ligamentum patelli they are attached to the tibial tuberosity. The painful swollen tibial tuberosity is seen in 14-year-old boys who are playing football. It is basically osteochondritis, and goes by the name of Osgood Schlatter's disease. Then you look at it posteriorly, you see the capsule. This is the capsule. These are the arcuate fibers arching around the popliteus tendon, which is getting attached to the soleal line of the tibia. Under the popliteus ligament, you can see a flap of the synovial membrane, which is called as subpopliteal bursa. If the neck gets occluded, it becomes swollen, then it is subpopliteal cyst or Morand-Baker cyst. The Morand-Baker cyst is a swelling in the popliteal fossa, which becomes more prominent when you extend the knee. Now, synovium is a sac which is folded on itself till the articular margins of the lower end of femur and upper end of tibia. So, in front is a hole through which the patella looks inside. Posteriorly, the sac is pushed anteriorly by the anterior and posterior cruciate ligaments, creating a fold of synovium, dividing the synovial cavity into the medial and lateral compartments. From the tip of this arise projections, which are called as alar ligaments. They have baroreceptors or pressure receptors, which are measuring the synovial pressure in the medial and lateral compartment. So this is the outside this, you see the patella looking into the synovium, and outside is the medial patellar retinaculum and the lateral patellar retinaculum, consisting of the epineurosis. This is the epineurosis of the vastus medialis and lateralis, the capsule, and the deep fascia. So this is the medial and lateral patellar retinaculum, and this is the structure of those retinacula. Then you see that in the lateral view, the synovium will project under the quadriceps muscle, and on its tip will be attached the articularis genu muscle, and this is the suprapatellar pouch, which is usually swollen when there is synovial effusion. In the infrapatellar region, the synovial is lifted off. The synovium is lifted off by the infrapatellar pad of fat, which is usually swollen and painful. Then you have the ligamentum patelli and the tibial tuberosity, and this tibial tuberosity can show the Osgood-Schlatter's disease. Behind you have the capsule. Capsule has a hole so that the intracapsular popliteus can come out and get attached to the tibia. So here the suprapatellar pouch is important in synovial hemarthrosis and synovial effusion, and you can aspirate the joint from the suprapatellar pouch. When there is a hemarthrosis, the two ends of the suprapatellar pouch will get adherent, and this will prevent flexion of the knee. So you will need an adhesiolisis, arthroscopic adhesiolisis in the suprapatellar pouch, so that the flexion can be regained. Simultaneously, you may have to cut the medial and lateral patellar retinaculum up to the collateral ligaments to allow flexion of the patella. Patella can show chondromalacia, can show fractures, patella, and can show recurrent dislocation. Then you have these menisci, and you must remember the intercondylar ridge. Here is the ligamentum patelli attached to tibial tuberosity, the infrapatellar pad of fat. Then you have the Medical College Lucknow, the medial meniscus, the ACL, and the lateral meniscus. And Lucknow Medical College, lateral meniscus, medial meniscus, posterior cruciate ligament. The meniscus is attached to the femur and to the tibial plateau by what are called as coronary ligaments, which are inside the capsule. The lateral meniscus gives weight to the popliteus tendon, which becomes extracapsular and gets attached to the posterior part of the posterior surface of the upper tibia. Now the meniscus usually tear when there is a rotation on a flexed knee, as in footballers. The tears can be radial or bucket handle. The diagnosis is by Mac-Murray's test. And locking of the knee. If there is a radial tear, you ignore it. So radial is to be ignored. And if there is general degeneration, you have to balance it. Sometimes you have to excise it, but mostly you can repair the medial meniscus arthroscopically, especially if it is involving the outer third, which is vascular and which will heal. You use a fibrin glue in the tear and stitch it by a stitch so that it repairs. So lateral one-third meniscal tear can be repaired. Then you have the articular cartilage. So congenital problem is osteochondritis dissecans. Radiologically, you can present with pain and locking, and you can see it in the joint and you have to excise it. Then there can be infections like in uric acid, like in osteoarthritis, where there is detritus formation and eburnation, which you have to know what they are. Then uric acid, and then ankylosing spondylitis and rheumatoid arthritis. All these are inflammations. So they lead to erosion of the cartilage when the movements become painful. So there is a pain in the range of movement if there is a femoral articular cartilage involvement, and the whole movement of the tibia is articular cartilage is involved. Then there are kissing erosions, then fibrous ankylosis when they get connected by fibrous tissue, and then finally bony ankylosis. Rheumatoid arthritis, ankylosing spondylitis, septic arthritis have to be seen for this. In nerve involvement, there are neuropathic joints. Muscles can be contracted. If the muscle is paralyzed or lax, or ligaments are lax, it can lead to triple dislocation. That means the tibia is pointed backwards, externally rotated and flexed in relation to the lower end of femur. Now in paralysis, you have the quadriceps paralysis, and we have again a very good video of high steppage gait and quadriceps paralysis, what compensates and how to treat it. So this is about muscles.